Good morning. It's a real pleasure being here today. Triple-negative breast cancer, as you know, is a very difficult to treat subtype of breast cancer. Until now, we struggle to have targeted therapies, and in contrast to what you just heard about ER-positive disease, most of the treatment was chemotherapy. Now we are moving to early triple-negative breast cancer here. We were here a year ago and talked about the first data with immunotherapy in metastatic triple-negative breast cancer. Now it's a pleasure to present data in early triple-negative breast cancer where, if the trial is positive, we hopefully achieve cure, which is obviously the most important endpoint from my perspective. It's well established that if you give chemotherapy before surgery in early triple-negative breast cancer, that those patients where the cancer disappears, and this is what we call a pathological complete response, that those patients have a long-term benefit. There's a large meta-analysis that shows patients who don't have tumor left in the breast at the time we do the surgery, so after chemotherapy, have a massively longer recurrence-free survival and have an overall survival benefit, as you can see here with a hazard ratio of 0.24 for event-free survival and 0.16 for overall survival. Now, to set the scene, in the past we gave anthracyclines and taxanes, and we achieved this path-CR in about 40% of patients. If we add in platinum, we achieve a path-CR in around 52% of patients. And both the FDA and EMA have said that we can use path-CR as an endpoint for accelerated approval in the neoadjuvant setting, but we will obviously have to demonstrate the longer-term benefit in terms of really reducing recurrences. If you look at the KEYNOTE-522 trial, it was a trial for patients with early triple-negative breast cancer. Patients either had T1C tumors with lymph node involvement or larger tumors irrespective of the lymph node involvement. Patients were randomized between the immune checkpoint inhibitor pembrolizumab or placebo, and they received 6 months of preoperative chemotherapy, first 12 weeks of carboplatin and paclitaxel, and then 12 weeks of what we call AC or EC, all the way through either with pembrolizumab or with placebo. Patients then had surgery, and this is where we define or determine the path-CR. And after surgery, they continued just on the immune checkpoint inhibitor or placebo for another 9 cycles. So the trial had 2 endpoints, and we're presenting the final results for the first endpoint, which is path-CR, the complete disappearance of the cancer from the tumor. But we will also show very early results for event-free survival, so for the rate of recurrences, at a median follow-up of only 15 months. Now, you will say that's very short for breast cancer, but in triple-negative breast cancer, if you don't achieve a path-CR, the recurrence risk in the first 3 to 5 years is about 40 to 50%. So these events, unfortunately, happen relatively early. If you look at the final results for path-CR, you can see that in the control arm with platinum, the path-CR rate was 51.2%, and this was significantly increased to 64.8% with the addition of pembrolizumab, with a delta with a difference of 13.6%. There's a huge ongoing debate about selecting patients. PD-L1 is one of the markers we've heard in other trials. And so we did an analysis, Preplan analysis in patients with PD-L1 positive tumors, determined by an assay called 2-C3, and PD-L1 negative tumors. And as you can see, both groups have a significant benefit. Again, the delta is 14.2%, the difference between placebo and pembrolizumab for patients with PD-L1 positive tumors, and 18% for patients with PD-L1 negative tumors. At this very early time point, we have very preliminary data for event-free survival because the follow-up is only 15 months in a curative setting. But what you can see is that there's already a difference between the 2 curves. If you look at the actual events, we had 7.4% of the patients in the pembrolizumab arm unfortunately experienced recurrences. 11.8% of patients on placebo experienced recurrence. The hazard ratio is 0.63. This didn't meet the very, very strict criteria for significance at this very early time point. As you can see, the bottom of the slide is the criteria was 0.00051 to meet, which was a very, very high bar, but we will have subsequent event-free survival analysis coming out very soon. The estimated 18 months event-free survival is 91.3% with pembrolizumab and 85% in the placebo group. Now, one key consideration is what's the cost in terms of side effects. And if you look at the side effects in blue with pembrolizumab and in the, I think the colors don't come out quite, in the lighter color with placebo, you see it looks relatively comparable between the two arms. We haven't really had clearly new safety signals. We have slightly more rash with pembrolizumab, but otherwise there's very little different between those two groups on average, at least in the common side effects. This is in the phase before surgery, where immune therapy is given together with chemotherapy, so most of the side effects you see here are side effects of chemotherapy. If you look at the phase after surgery, where patients receive placebo alone or pembrolizumab alone, you can see the rate of toxicity is very low, and there's very little difference between those two groups. So our conclusions at this point in time is that KEYNOTE-522 is the first prospective randomized phase 3 trial in early triple-negative breast cancer, spanning from the neoadjuvant to the adjuvant setting. We conclude that the addition of pembrolizumab to platinum-containing neoadjuvant chemotherapy, which is the highest bar in terms of path-CR rates, resulted in a statistically significant and, in my opinion, also clinically meaningful increase in the path-CR rates from 51.2% with chemotherapy alone to 64.8% with pembrolizumab. Neoadjuvant pembrolizumab plus chemotherapy, followed by adjuvant pembrolizumab, showed a favorable trend for EFS compared to chemotherapy alone at this very early time, but with only 50 months follow-up. But of course, subsequent data will be presented relatively soon. The safety profile so far is consistent with what we know for each of the regimens, and patients obviously continue to be followed up for recurrences, for survival, as well as safety. As you're probably aware, pembrolizumab has been granted breakthrough therapy designation based on KEYNOTE-173 and I-SPY 2 trial, and we continue to share the results with you in the future. Thank you.